great pleasure to have Dr. K. Shiva Kumar. It is a very well-known and passionate interventional cardiologist who is very familiar to most of us, and many of us have learned many things in the past. I request Shiva Kumar to proceed with his talk.
I thank the chairpersons, the Andhra Pradesh CSI organizing committee, Dr. Harita, everyone for the kind invitation. When we look at the atrial septal defect closure in an adult, a brief introduction about what are the types of defects. We know that secondum defects contribute about 80%, primum about 10%, and sinus venosus about 10%. And why should we think about a catheter closure? Catheter closure avoids cardiopulmonary bypass, cross clamp, it reduces hospital stay, morbidity, effusions, transfusions, rapid return to employment, scarless. So the next question is, who is not amenable? If you look at the anatomy of an atrial septal defect, around 60% of them can easily go to the cath lab for a non-surgical closure. But what cannot go to cath lab will be secondum ASDs larger than 35 to 36 millimeters. ASDs with deficient inferior posterior margin, multiple ASDs, ASDs with borderline PVR, ASD in the elderly with restrictive LV physiology, patients who don't have a femoral vein access, patients who have, for example, a sinus venosus ASD or combined sinus venosus and secondum ASD. Let's talk about all these unconventional areas. Secondum ASD more than 35 to 36 millimeter. American guidelines permit use of device up to 30. In fact, 40 device is not recognized in USA. European guidelines are a little bit more liberal, they accept 40. So automatically only 35-36 millimeter defect should be possible to be closed by a device. And moreover, whenever defects are larger than 35, most of the time 1 or 2 rims may be deficient or absent. And it's invariable in adults more than 30 years who have a large ASD who will be referred to surgery because of this criteria. So what is the experience of devices more than 40? Fortunately, a lot of Chinese vendors started manufacturing devices at much larger sizes. So we looked at what is the data of devices that are more than 40. This period of 2013 to 2018, 62 patients who received devices between 40 to 48. Of course, in the next 3 years, 34 more patients got added up, and so now we have a cumulative experience of close to about 100 patients who had devices that are more than 40 millimeter. The usual age group, weight, the defect, mean diameter of the defect was 38.3 plus or minus 4.7, and almost 50% of them had deficient margins. We are talking about adults, so a fair number of them had atrial arrhythmias already. Pulmonary hypertension, flow-dependent pulmonary hypertension, almost 40% of the patients. However, they all had operable PVRI. The QPMQS is quite high. We all know that it's a dependency. A QPMQS can be 2:1 in a child of around 10 years, but when the child becomes 30 years or 40 years with associated coronary artery disease, associated hypertension, being a dependency, QPMQS will increase. And that is because of slightly elevation of left ventricular end diastolic pressure. So this is a 46 millimeter device that's going in a 42 millimeter defect. The other one that we are showing is a 48 millimeter. You can see that this patient has a 6-sinus syndrome, AV nodal disease, is having dual chamber pacemaker. It's a 48 millimeter. So what we find is that devices of larger size are also reasonably safer, provided we choose the appropriate patient. In fact, custom devices are available even up to 54 millimeters, and this actually removes size as a criteria for selection of the patients. The second one is defects with deficient margins. We don't choose patients with posterior margin deficiency because there is a high chance of device slipping out, inferior margin due to device embolization, anterosuperior margin due to device erosion. So what is an absent margin? I'm showing 2 planes. This is the bicaval plane, and the other one is the horizontal plane. You can appreciate in this bicaval plane that there is no inferior margin at all, but in the horizontal plane there is a small posterior margin. So, our previous idea was that if suppose there is one margin deficiency, there are absolute contraindications, but we can realize that if you are able to anchor the device about 300 degree of a 360 degree circumference, that should be good enough to take care of stability of the device. So this is a 46 millimeter device that is running in a patient whose ASD is about 41 millimeter. You can see this frame here. So these procedures sometimes can be safer, but what we need is a careful understanding that the other margins are adequate. So this is the same patient who had an absent deficient inferior margin in the same bicameral view there. We're able to see that the left atrial disc is actually hitched on properly. Just another example. This is an absent posterior margin. This is a horizontal plane imaging, and this is a bicameral plane imaging. In bicameral we have a small inferior margin, but in horizontal plane we don't have a posterior margin. The same principles. If you have an anchor in the other zones, it may be possible. What we need is a thorough understanding of the transesophageal echocardiography. So you can achieve a closure. This is showing the same absent posterior margin, how the device hitches against the walls of the atria and ensures the closure. So what did we learn? We know that there are certain margins, but a deficiency or absence of one of the margin can be compensated by adequacy of the other margin, and hence it may do the work. Multiple atrial septal defects is another problem. If they are thin strands, then they can be closed with a single device, but if they are quite far away, they will need multiple devices. And if they need multiple devices, the questions that come to our mind is device stability, device to device interaction, and how to assess their size precisely. So this is two devices deployed. So we looked at our results of patients who needed multiple devices. So a group of around 25 patients over 6 years. What is the conclusion? It's feasible and safe. A careful echocardiography, sometimes even a balloon interrogation is important for successful closure. Sometimes it needs to be simultaneous, which means you should have bilateral groin access. And in fact, there were, contrary to our expectation, there were no additional new complications. The next question that comes in adults is ASDs with borderline PVR index. What is the definition of an acceptable criteria for a closure? The QPMK should be more than 1.5 with the PVR index of less than 5 good units. PVR SVR ratio of less than 0.3. If these patients have high values more than this, they should have an acute vasodilator testing with nitric oxide. And patients who get a positive vasodilator response, which means a 20% reduction in PA pressure or PVRA or PVR SVR ratio, should have a partial closure. What is the meaning of partial closure? Using a fenestrated device. So this is a fenestrated device which is seen on fluoroscopy. This is the fenestration, and this is seen on transesophageal echocardiography. This is the fenestration. So leaving behind a 6 to 8 millimeter as a pop-off, so that in case if there is a future elevation of the pulmonary vascular resistance, this pop-off will ensure that these patients do not have progressive right heart failure. Of course, with the intensive pulmonary vasodilator therapy, these patients are likely to have a more stable course. So this is the fenestration. 3 years later, you study these patients hemodynamically to find out what is the PA pressure. You just cross the fenestration in order to see what is the left atrial pressure. So the fenestrations do work permanently. And this is 6-year follow-up of a fenestrated device, transesophageal echocardiography, which shows that the fenestration is still good. Patients with restrictive LV physiology, adults chronically volume overloaded left ventricle and elderly may fail to accommodate the sudden closure of a large ASD. The problem is very profound. If they have an uncontrolled associated systemic hypertension, coronary artery disease with diastolic dysfunction, more notorious in renal failure, and if some of these patients have diuretic resistance, they are the maximally affected ones. But these patients are very sick as well. To show an example, a very elderly patient, atrial fibrillation, severe congestive heart failure. You can see the cardiovascular ratio. Almost for 2 to 3 months in a year, the patient will be in the hospital receiving heart failure therapy. The patient cannot tolerate anticoagulation due to recurrent bleeds as well, so he is getting a closure of the atrial's appendage. Now we look at the size of the left ventricle and the left atrium in comparison to the entire heart. It's truly a restrictive area. So this is the size of the left ventricle, see the size of the heart. The entire thing is only right atrium, right ventricle. So obviously, it's a classical example of a restrictive LV physiology. So a 44 millimeter fenestrated device is going up here. The patient is having an atrial appendage that is being closed, and this patient is continued on aspirin with 4-year follow-up. Is doing quite well. So the protocol in these patients with elderly with restrictive LV physiology will be pre-treat them, control the blood pressure, diuretics for heart failure. LV dysfunction can be managed with milrinone dopamine prior to the procedure. Check LVD in every adult before closure. If it is high, check after balloon occlusion or device occlusion. Consider finasteride device. Post-procedure, continue diuretics for a longer period. Caution to be exercised if the patient has renal failure or diuretic resistance. Another problem that comes in elderly is sometimes absence of vascular access. This is a patient who was an adult whose echo windows will be poor, so you cannot identify very clearly whether they have an IVC. Hepatic veins will look like IVC. So this patient had azygous continuation. This patient had some chronic DVT and was collateralized. But no longer this is a problem. These patients get transjugular device closures. This is an example of a transjugular device closure. The last one, superior vena cava type of ASD, SVC type of sinus venosus ASD. This used to be reasonably common in an adult because these patients tend to be missed in their early childhood. It's not easy to pick up a sinus venosus ASD by a conventional transthoracic echocardiogram because it's in one corner of the heart. It needs a subsified view and often they are missed. So it's quite common to see many sinus venosus ASDs in adult practice. The new transcatheter option is you put in a balloon across the SVC junction, have a parallel catheter in the right upper pulmonary vein, and you see that the balloon is actually completely occluded the SVC ASD and the pulmonary vein is getting rooted into the left atrium. You check it with echocardiogram as well. This is the balloon across. You can see that there is no flow across the sinus venosus ASD. So these patients get a covered stent. This is a covered stent that is getting deployed. Here you can appreciate that the right upper pulmonary vein is flowing only into the left atrium with no residual flows into the right atrium. You are continuously monitoring the right upper pulmonary vein pressures. So this closure is one of the recent advances in sinus venosus ASD, which has actually created a good hope for patients with sinus venosus ASD. This is our publication in Circulation and how to do it in Annals of Pediatric Cardiology. So combination, sometimes these patients have combinations of large secondary ASD with the sinus venosus ASD, and so you just do both separately. This is a secondary ASD which is being closed with a 36mm device and a sinus venosus ASD. So to summarize, ASDs are increasingly dealt in the cath lab and rarely need surgery today. Large secondary ASD more than 40mm, deficient limbs, borderline PVRA, ASD in elderly, ASD with restrictive LV physiology, multiple defects, ASDs without femoral vein access, SVC type of ASD are all possible to be taken up for a transcatheter closure. This being the commonest grown-up congenital heart disease, this recent trend is actually a welcome trend for patients as well as many of the treating cardiologists. It's very difficult to send a 50 or 60 year symptomatic atrial septal defect patient to surgery, and when we know that it can be safely be performed in the cath lab, it's actually something that is worth considering. Thanks a lot for your time.
Thank you, Dr. Shiva Kumar, for your comprehensive and illustrative lecture. And now, if there are any questions to Dr. Shiva Kumar, please. It seems there are no questions, so we'll proceed to the next talk. Thank you, Dr. Shiva.